So, if we listen to a lot of the talk coming out of some of the medical fields and within some of the medical advertisements that we might see broadcast to us, we might think that diabetes is a pandemic that everybody is going to have to face at some point in time. But what is diabetes and how does it relate to the pathology and pathophysiology that we might face within our body? Well, let's talk about that.
Warning: the following presentation contains information that might contradict what you have previously heard, or believed to be true, about how the human body works, and contains material that is not suitable for closed-minded individuals. Enjoy!
So if we look at a lot of the advertisements, a lot of the discussions relates to diabetes, a lot of it's going to be dealing with checking of blood glucose levels, using monitors to make sure that we are within normal ranges and tracking our sugar, tracking our activity, tracking our diet throughout the day. But what is diabetes and how is diabetes actually going to kind of affect our health? This is where we have to understand what the causes of diabetes happen to be in order to understand the disease of diabetes. So they're able to fight and work through a lot of the misinformation and disinformation that gets presented to us about the disease. So, what is diabetes? Well, what we're really talking about here is diabetes mellitus. There are different types of diabetes. And this type of diabetes is basically a condition where we think about having too much sugar in the blood. But that's oversimplifying the idea here. What we're really talking about in terms of diabetes mellitus is type 1 and type 2 diabetes. There is other types of diabetes mellitus in here, but we're really going to focus on type 1 and type 2. Type 1 is the inability to generate insulin to regulate glucose uptake at three key tissues of the body: skeletal muscle, liver, and adipose tissue. Type 1 diabetes comes about due to the cells within the pancreas not being able to produce insulin. And because they're unable to produce insulin, we're unable to have an insulin response. Type 2 diabetes, on the other hand, are symptoms of metabolic disease, metabolic syndrome. And so we have an inability to respond to insulin signalings at skeletal muscles, at the liver, or at adipose tissue to uptake additional glucose from the blood. So we start looking at what insulin is actually doing in terms of glucose regulation. It's not about normal glucose conditions, it's when we have too much glucose coming into the body. Usually when we have large meals where we're consuming somewhere in the neighborhood of 1 to 1.2 grams per kilogram of body mass of glucose within a meal, or where we're over consuming foods throughout the day. With all meals, we're going to see insulin release. With all meals, we're going to see insulin spiking. And the idea about insulin spikes and the idea about insulin in general as relates to diet and relates to sugar consumption, we've talked about previously. But let's focus predominantly on what's happening at the receptors and how we can go about looking at the conditions of type 2 diabetes, as that it tends to be the principal form of diabetes mellitus that we look at or discuss in terms of a pathological condition. So when we start looking at normal conditions within the blood, we're able to get glucose from the blood into the cells based off of non-insulin dependent glucose transporters. Glucose transporter 1, glucose transporter 2, glucose transporter 5, just to name a few. And so we have insulin receptors, but the insulin receptors are not responding when we have normal blood glucose levels. It's not until after we have an exorbitant amount of glucose intake that we have to worry about insulin or worry about the insulin receptors and how the insulin receptors are working in order to maintain glucose within the body and maintain glucose within the cells. When glucose goes into the cells, it will undergo various types of pathways and various types of processes, which will be different when we start seeing with the insulin. So insulin here represented with the yellow stars is going to interact with the insulin receptor when we have a lot of glucose in the blood. That is going to upregulate a special type of glucose transporter known as the GLUT4 transporter. This GLUT4 transporter is going to allow for a larger amount of glucose to be taken in by the cells. And this really is at three key tissues: the skeletal muscle, the liver, and an adipose tissue. All the other cells, all the other tissues that we look at in terms of utilizing glucose are doing it independent of insulin and independent of the GLUT4 transporter. When we start getting normalization of the blood glucose levels, we're going to see a dissociation of the insulin receptor and a downregulation of the GLUT4 transporter, allowing for that glucose to come in to undergo various types of chemical processes, various types of chemical pathways that insulin is going to stimulate based off of the nutrients that we see within the bloodstream. So, what are the effects of insulin? What are we going to see besides this upregulation of the GLUT4 transporter? Well, we're going to see things like glycogenesis. We're going to be making glycogen from those glucose molecules that are coming into the cell. That glycogenesis allows us to store glucose for later on. We're going to see lipogenesis. We're going to see storing of fuels, storing of nutrients as lipids. We're going to see protein synthesis. We're going to see making of new proteins in anabolic responses. But more importantly, we're going to be blocking lipolysis and blocking glycogenesis. So what we're looking at, what we're seeing within this type 2 diabetes is somehow not responding to those signals. So we will see responses to insulin, but we will not see responses to insulin based off of that GLUT4 transporter. So we will see signals within the cells, particularly within the adipose cells, within the skeletal muscle cells, and within the liver cells that are still going to allow for the lipogenesis to take place. That may still allow for the protein synthesis to take place. But what we're not going to see is we're not going to see signals that are going to lead to changes within the cells that are going to allow for the glycogenesis, the making of new glycogen, or getting that blockage on the lipogenesis, the lipolysis. So we're still going to see accumulation of fat masses, accumulation of lipids within cells for someone that has the type 2 diabetes. We will see the same exact thing for someone with type 1 diabetes, but it's not because of the loss of the insulin response, it's because of the lack of insulin coming in. And we have that loss of insulin in terms of the response on the type 1 diabetic. What we end up seeing is we end up seeing a change in inflammatory signals, a change in inflammation taking place, and that change in inflammation taking place leads to other cofactors, other comorbidities that get associated with the type 1 diabetes. But how does the change in receptors come into play when we start looking at this type 2 diabetes? So what does this look like at the cellular level? What is this going to be in terms of the change that we see with the type 2 diabetic, knowing that we're going to have a insensitivity, a lack of responsiveness to that insulin signal? And this is where we start looking at what's referred to as the change in sensitivity of the receptor. And so under normal conditions, we should have a normal response, which means that when we have a stress within the body and a stress within the cell, they should be the same. But when we start looking at what's taking place within the type 2 diabetic person, the stress in the cell is not matching the stress within the body. So the stress within the body is needing a clearance of glucose within the bloodstream, a reduction in inflammation within the body. And all of these changes that are taking place are not corresponding to the changes that are necessary within the cells themselves, which leads to an overload within the cell, a blocking of the hormonal signals, a blocking of the changes that should be taking place within the cell to the stress signals, to the hormone signals that are taking place. If we look at it in terms of the insulin itself, what ends up happening is that changes in inflammation, changes in metabolites, changes in oxidative stress leads to changes in the signaling cascade that comes away from the insulin receptor. We block the insulin receptor system, and by blocking the insulin receptor system, we end up blocking the downstream, the effects of that insulin receptor on changes within the cell that should lead to the upregulation of the GLUT4 transporter. So how do we come about? How do we get to those effects? It starts off with changes in behavioral responses where we don't get the correct psychological attraction to exercise stimulus. We have a reduction in physical activity. That reduction in physical activity leads to a change in our nutrition. Changes in age, changes in adiposity, how much fat mass we have, lead to systemic changes, lead to changes in the cardiovascular system, leads to changes in the musculoskeletal system. That leads to changes in the way in which the receptors are regulating themselves, which leads to an anabolic dysregulation. It's this anabolic dysregulation that leads to the diseased health status, that leads to the increase of fatty acids, that leads to a reduction in the breakdown of fats, that leads to all of the issues that we look at in terms of the metabolic factors. If we tie in the poor diet with the low exercise, we get that change in inflammatory signals. It can also lead to an exercise aversion. It can lead to changes in food intake. It can lead to changes in inflammatory signals that's going to lead to a reduction in our sensitivity to leptin and to insulin, which is going to cause changes in our overall food intake. All of this leads to changes in circulating levels of lipids, circulating levels of insulin, circulating levels of glucose. That leads to the syndromes of overfatness and of metabolic syndrome, that non-communicable disease, the liver disease, the kidney disease, the neuropathies, the cardiovascular, and the cancers, that gets lump summed in with all of the effects that we see with type 2 diabetes. It's not that type 2 diabetes is causing all of these things or all these things are causing type 2 diabetes. It's the fact that they are all lumped together due to either consumption of metabolic disruptors, poor diet, poor exercise, poor physical activity, exercise aversions that can come about because of poor planning, poor development of exercise plans when we were young, that leads to changes in inflammatory signals, that lead to changes in the way in which the body and the cerebral cortex, the brain, are going to respond to insulin and to leptin, that lead to abnormal growth signals, that is going to cause all of the non-communicable diseases that we think about when we think about metabolic syndrome, of which type 2 diabetes happens to be one. And so what happens if I allow for all of this inflammation to accumulate? This is where we get the mess up scenario. This is where we get the metabolic issues, the non-communicable disease issues that come about, that is the hallmark of the type 2 diabetes. Where, once again, if we look at it in terms of the diet issue, the metabolic disruptors leads to improper food intake, and it causes the same whole cascade of effects that we saw with the poor exercise and poor diet in terms of the non-communicable disease and the overfatness issues. And this is where a lot of people will indicate, well, if you just have a healthier diet, you won't have type 2 diabetes. If you just reduce the amount of sugar in your diet, you're not going to have type 2 diabetes. But it's not that simple. And it's not that simple because of the anabolic dysregulation issues, the high amounts of inflammation and low amounts of growth factor, the abnormal growth signals. That's going to be the root cause for the insensitivity coming into play due to the changes in the intracellular responses that we don't see being correct. When we start looking at the overall, what can we do about this? We have to remember that we have this excessively complex interaction of factors that we've talked about previously that is going to lead into all of the sociological and psychological and cognitive drives or aversions towards doing things that are pro-health or anti-health, that will lead to changes in body morphology, that lead to changes in overall health, that will impact my level of oxidative stress, that will impact my level of fat accumulation, that will impact my overall disease status, that will impact my metabolism, and my metabolism impacting my overall health. Something that we have talked about previously in terms of a lot of the misconceptions as it relates to specific sugars within the diet and diabetes. And I recommend going ahead and listening to the full podcast that we have as it relates to that issue if you want more information. We've also discussed the idea about we're getting stuff wrong in terms of the treatment options that we give for people who have diabetic, or if we're even able to control the pre-diabetic condition. Well, thanks for listening. Hopefully you got a little bit out of the quick talk about diabetes and how diabetes comes about. Please make sure you check out the podcast for more information. Links are in the description and in the caption. And please stay tuned for more discussions about different types of diseases as we continue to progress with the pathophysiology discussions here. Please make sure to follow us on all the various platforms here on YouTube, as well as the podcast, the written stuff in Substack, as well as quick takes on Instagram and on Threads.